Hello and welcome to your regional rotation. We hope you enjoy our time with us and come to love regional anaesthesia as much as we all do. The purpose of the talk today is to really give you a flavour of regional anaesthesia, why it's important, and some of the decision factors that are important when you take on the scheduling role over at OSC. So the outline for today is firstly to go through why regional anaesthesia is important, then move on to some of the factors that we use when deciding which and what type of block to do, then to go through pre-op and PACU PRN blocks, go through a little bit of the knowledge to ascertain whether a patient needs a catheter or a single shot technique, and then go through some special patient circumstances. So much of modern anaesthesia is very much like this picture, where there's lots of choices, lots of techniques that we can choose between, and really we need to know where regional anaesthesia falls in amongst all of these choices. Is it important, and should we be doing it? And the short answer to that question is yes, regional anaesthesia is vitally important to modern anaesthesia. So the patient aspects of superior pain relief is what it's known for, it's what it's appreciated most for amongst patients. However, there are very important other benefits of regional anaesthesia: patient safety, impacts on patient recovery, and favourable economics when it comes to hospital stay and hospital discharge are all aspects of why regional anaesthesia is important. So let's look at some of those benefits in more detail. Here at Stanford, we're very lucky to have the research leaders as part of our faculty, and that has led to lots of these benefits being studied in randomized controlled trials, in review papers, and we have very strong evidence to back up these claims. So first and foremost, post-operative pain is one of the greatest concerns for patients. It's what they are most worried about amongst all of the things within their perioperative journey. And regional anaesthesia is vitally important in improving that and giving them a better patient experience, especially with nerve block catheters. Importantly, there's some evidence that it can reduce cancer recurrence. Cancer recurrence is associated with local tissue inflammation, local antioxidant levels, and regional anaesthesia blocking that process has been shown to have some effect on cancer recurrence, which is huge, obviously. There's reduced mortality. Regional anaesthesia affects perception of pain, affects the activation of the sympathetic nervous system, and that amelioration of the stress response has a knock-on effect on mortality, which is studied and proven. There is also now emerging evidence that joint outcomes are improved. We know that better pain control in the short term had very good effects on patients, and now there's evidence to show that actually getting up and about and complying with your physio in that early post-operative phase carries on beyond the short term. There are also very strong economic reasons for why regional anaesthesia is very important. It can reduce your hospital stay. It's the cornerstone of several ERAS pathways, which reduces your overall hospital admission and costs to the hospital. It allows you to avoid a general anaesthetic, again reducing your duration of hospital stay, and it can also reduce the amount of GA required as well. In the current climate of the opioid crisis, it obviously allows you to be opioid sparing. It can reduce that risk of opioid-induced hyperanaesthesia. And there's also very strong evidence that it reduces your incidence of chronic pain. So in that patient population, which is particularly at risk of chronic pain, regional anaesthesia is huge in their management. As we've also alluded to in the previous slide, it reduces your surgical response, so that early incidence of complications is reduced as well, which again has economic impacts for the hospital. So you would think with all of those benefits that regional anaesthesia would be offered to anybody and everybody that had surgery. However, all regional anaesthesia techniques do have risks, and patients afterwards will have some degree of impact. So they may well have a numbed limb or a insensate limb, or they may well have issues with blood pressure if it's an epidural. And so those factors often play into the traditional surgical decision pathway for whether regional anaesthesia is appropriate. And really, the decision there is whether the benefits outweigh these potential risks, the post-op status of the patient, and whether it's worth a time delay potentially. However, for regional anesthesiologists, this decision-making is not quite as clear-cut, and we know that there are lots of factors that play into how and when we offer regional anaesthesia. So we usually think of patients as to whether they would benefit from regional anaesthesia. The answer to that is usually yes. Then we need to look more into the patient to see if there's any specific issues we need to consider. And then we move on to the what block, when, and whether this patient deserves a catheter or not. Picking up that last point about catheters, our decision to offer a catheter versus a single shot is really guided by the following 3 points. So firstly, what the average pain journey is for that particular surgery. Some surgeries, the bulk of pain was in the first 12 to 24 hours, where a single shot may suffice. Other surgeries, for example, total knee replacements or shoulder operations, there the pain is expected to last for longer. And then in that situation, a catheter would serve the patient better. We also need to think about what the patient's expected to do post-op. Are they expected to have full range of movement? Are they expected to do their physiotherapy straight away and as soon as possible after surgery? And in which case, a purely sensory blockade is something that we would aim for. And then the third point that we consider when offering a catheter or a single shot is whether the patient is able to care for a catheter if the patient is to be an outpatient. Are they able to carry the pump? Are they able to manipulate the buttons? Would they be able to call for help if required? Another major decision that we need to make whilst covering the regional service is whether to do a block pre-op or whether to offer it PACU PRN. So the decision to offer it pre-op is really governed as to the impact that block would have on intraoperative management. Would it allow the patient to avoid a GA, to have surgery awake, or to have surgery under a MAC? That would have huge benefits on avoiding all the side effects of a deeper anaesthetic or having a general anaesthetic. For patients who are susceptible to chronic pain, that avoidance of opiates, the avoidance of wind-up is hugely important and would influence whether the patient had a pre-op block or not. If there is anticoagulation to be given during the procedure, for example in IR procedures, or for patients undergoing procedures on bypass, that may impact on whether or not you can offer a pre-operative block. PACU PRN blocks, we really have to look at what is the management post-operatively. So is this patient going to go to the ICU and remain sedated and have their pain relief delivered via an infusion? Will this patient require a motor examination and need to have no block after their operation? Will this patient be an outpatient and need to have full power to mobilize around their house? And will this patient be weight bearing? All of those aspects will impact on the block timing choice. So here is a list of special patient circumstances that influences our decisions in regional anaesthesia. This is obviously not an exhaustive list, but some of the more common ones to be aware of. So we come across patients with existing neuropathy not uncommonly. It does not mean that they cannot have regional anaesthesia. However, it impacts on the tolerance of nerve damage afterwards, and we also need to be very careful and document the extent of the existing neuropathy. Some conditions mean that the chance of nerve damage is more common, and we need to be careful when offering these particular patients regional anaesthesia. Chronic pain is another big subset of patients where we need to pay additional attention. So chronic pain patients often have spinal cord wind-up, so the same level of tissue injury causes more pain, and so these patients for the same surgery which may not warrant a regional anaesthesia in other patients do warrant having a regional anaesthesia technique, especially pre-op and especially catheters, so we can avoid that wind-up and that increase in their symptoms. We also need to be wary of the comorbid conditions of the patient, which may influence how they tolerate side effects. For example, in a respiratory cripple, phrenic blockade for an interscaling block may not be tolerated. We also need to be wary of patients who are on anticoagulation. Again, it does not preclude regional anaesthesia. We have a very useful guidelines through ASRA, which is available on the ASRA COAG app, which gives you guidance as to which anticoagulants you can give regional anaesthesia with and the timing for discontinuation. The next patient circumstance that we need to be aware of are current local anaesthetic infusions. So patients may be on a current lidocaine infusion to treat several sources of pain. We need to be aware of how long that infusion has been on for, and whether if we stop that and give it a nerve block, whether that precludes treatment of other areas of pain. Some patients have aberrant anatomy, which may be known about preoperatively, or may be found during pre-scan, and that influences what type of block we offer. Other patients may be unable to consent, either for an ongoing condition or temporarily secondary to drugs or the mechanism of injury, which may mean that a regional anaesthesia, which would have been opened for them, is no longer an option for them. So I hope this talk has given you a flavour of the types of decisions that we make whilst covering the regional anaesthesia service and convinced you that regional anaesthesia is vitally important to modern anaesthesia.